I was born in 1976. I grew up here. This building is who I am. The patients, doctors, nurses, and staff, they truly are my family. Some thought I wouldn't make it, but great leaders fought for me. They believed that I could change Ottawa, Canada, even the world. And they were right. By the time I was 30, I'd saved thousands of lives, was recognized internationally, and had collaborated with over 40 countries. I've performed over 500 heart transplants, discovered the world's first genetic risk factor for heart disease, combined care, research, and education in one place, leading the way for innovation in heart disease throughout Canada and the world. I'm always thinking of the future and learning from the past. But through all this, I couldn't have done it, not without the people. The people here have taught me that through great loss can come great triumph, and that fear is never as strong as hope. I can't stop until there's a cure, and I will spend every second of my life trying to save yours. Some might say I've lived 1,000 lives, but I feel I'm just getting started.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.
Hi, everybody. Thank you so much for joining us for this show today. I'm Dr. Peter Liu, Chief Scientific Officer at the University. This particular show today, we are absolutely proud to have a world-renowned guest, and he's Dr. Randall Starling from the Cleveland Clinic, which is ranked #1 in the U.S. for heart care. And Dr. Starling is a university-recognized expert in heart failure and in cardiac transplantation, and also mechanical circular support devices, or quite often, people refer to as artificial heart. And he's a medical director of the Kaufman Center for Heart Failure, and he's also vice chairman of cardiovascular medicine at the Cleveland Clinic. And he's been a major investigator and leader in many of the clinical trials that established the use of new tools and treatments for heart failure today. And in fact, up till 2 weeks ago, he is the president of the Heart Failure Society of America, one of the premier organizations that all the heart failure experts get together. And in fact, it was one of the most successful meetings in Philadelphia, and featuring not only the best in science, bringing patients together with care providers, and also Shaquille O'Neal, who's putting forward a big step for heart failure all around. So welcome, Dr. Starling.
Very happy to be here.
And so you're definitely the heart failure expert in the world. So we want to take this opportunity to speak with you about the challenges of heart failure, and for our audience, to understand what the exciting advancements could be in this field. Maybe just for our audience at home or at work, what is heart failure? I know sometimes patients may confuse it with a heart attack, and not quite sure is this a serious thing, and they may see their parents maybe diagnosed with this condition, maybe just something that for our audience.
Yeah, thank you, Dr. Liu. I think that many patients come to see a physician. They're told they have heart failure, and it's a very misunderstood concept at times. In fact, many of us don't like the term heart failure because it sounds very negative, like,
yes,
this is a death sentence.
Yes.
I have a failing heart. So what I try to explain to a patient is that heart failure is more of a syndrome that could include shortness of breath, fatigue, maybe swelling, but patient can get that condition for many, many reasons. One could be a heart attack that damages the heart. One could be high blood pressure that's not well treated. It could be an abnormal heart rhythm. It could be a virus. So there are many, many ways that the heart might not function properly. And oftentimes the patient with a heart that's not functioning perfectly may have no symptoms whatsoever. But when they get recognized as having heart failure, it's generally because they seek medical attention because they don't feel well. They have swelling, they have shortness of breath, and in fact, as I think you would agree, probably the most common scenario when we meet a new patient is they've gone to an emergency department and been told that they had a respiratory infection before it's actually discovered it's a heart problem.
Absolutely, yeah. So I think it's much more common than people realize. Sometimes it gets misdiagnosed, and most commonly it's actually the emergency room that picks up the condition. And so, what are some of the things that patients can do when they recognize maybe some of these symptoms you mentioned, whether it's in their parents or in themselves, and should they go and see their physician? What are some of the things that can be followed up to make sure it is heart failure?
So that's a tricky question in that we don't want to create panic in the public over very common symptoms like being short of breath. But having said that, I'll reflect on what Shaquille O'Neal said to the audience when he was in Philadelphia, and his message was simple. He said, if you don't feel well, get it checked out. Go to a doctor. So I think that's the simplest, probably the most basic message. And if you go to your doctor and get checked out, whether you don't have to go to a cardiologist, it can be your primary care physician. But we have many tools now that I think the doctor will figure out if you have a problem to be concerned about. And if it does turn out to be related to your heart, there are plenty of experts in the US, in Canada, everywhere in the world that can figure out if indeed it's a heart condition. The term is cardiomyopathy that relates to a heart muscle problem, and that cardiomyopathy may explain the shortness of breath or the cough. And yes, the patient may wind up being told, you have heart failure. And that then triggers a whole cascade of where things could go next.
Yeah, but you're absolutely right. A lot of times, my patient may mention to me that, they thought it was just old age, and or that, this is just because, that their lungs not working well, and so miss the opportunity to get things checked out. But nevertheless, as you mentioned, the word heart failure tends to scare people, and a lot of patients, before says that, oh my God, if I get this condition, there's probably nothing can be done, and don't want to even find out about it. But that's not true anymore. Is that right? So are there any sort of advances from your point of view in terms of treating our patient with heart failure?
So I think that if I reflect from where I started, which was, say, 30 years ago in this field, working with one of my mentors in Columbus, Carl Lear, we had very, very few tools. Now we have many medicines, we have devices, and there's a video that I have on the website at the Cleveland Clinic, and in that video I make a statement, which I will abide by that statement to this day, which is our mission is to prevent or delay the need that a patient will ever need a heart transplant. So when we see a patient that has heart disease or heart failure, immediately we have so many diagnostic tools, and more importantly, perhaps so many therapeutic tools that I think that we are able to achieve not necessarily a cure, but in many cases a quote-unquote remission, where a patient is dramatically improved with the therapies that we have today. So we can talk about specific therapies if you like, but there are many.
So there is, in fact, hope for our patients, and in fact, the outcome is actually much better today than it was, certainly 30 years ago.
Absolutely.
And maybe you could actually, talk about some of the things, especially more recently, that's been very exciting, from your point of view in terms of heart failure treatment advancements, and certainly some being featured, at the Heart Failure Society meetings, and you personally, will actually address this at our upcoming lecture, later today as well. Maybe just a couple glimpses on things that excite you.
Yeah. So I think the most exciting area in heart failure is what is termed guideline-directed medical therapies, or guideline-directed management and therapy. So what does that mean? What that means is that we now in Canada, in the US, and Europe, we basically have a cookbook, if you will, that says when you see a patient with heart failure, here's the approach that you take. So let's just focus first on medication. So we have gone through, say, over the last 20 years, a progression from initially what are referred to as angiotensin-converting enzyme inhibitors, a very important drug that reduced mortality, improved survival, and outcomes. Next came beta blockers, another drug that was considered very novel at the time, dramatic impact. Then came another class of drugs that I'll for short call aldosterone antagonist, again, reduce the risk of death. So all of a sudden we had 3 drugs that we could give to most patients that have heart failure with weak heart muscle. And more recently, there's been a whole new class of drugs. It's a big word, but it's called ARNI for short. It's a new drug that has had an added dramatic impact, is replacing ACE inhibitors in many, many patients. And just less than a month ago, a brand new class of drugs was reported by our friend John McMurray and colleagues. That is a drug that was developed for diabetes that now we've learned on top of all the drugs, there's additional benefit. So that's drugs. And then when you combine that with devices that can be put inside the body very efficiently with great expertise nowadays, pacemakers, defibrillators, combinations, new techniques to monitor the heart from a distance. Both of us now can have a patient sitting in their bedroom that we can see electronically readings inside their heart.
I know, yeah.
So we have monitoring tools. We have devices without open heart surgery to affect leaking valves in the heart. So it's just an exciting dynamic area in cardiovascular medicine.
Yeah, so in terms of the recent, research findings, it's really, sort of now an exciting field to be in,
yeah.
And where we have now luxury of choices and the ability to actually give the right treatment for our right patients and still be able to monitor their response, both in the clinic and outside their homes. And so do you see that in the future, that patients, in fact, can be much more engaged, in terms of their care in heart failure rather than sort of being scared of it? And are there things that, whether you're doing at the Cleveland Clinic or, through your efforts at the Heart Failure Society, to actually get the patient to be more of a kind of a partner, in this venture rather than kind of just a passive recipient?
Yeah. So my friend Dr. Liu is a brilliant scientist, so he asks a very important question. And patient engagement, we think, is of paramount importance, which is one of the reasons why we made an initiative at the Heart Failure Society of America. As of September of this year, we have a patient membership category. So a patient at no charge can now join the Heart Failure Society of America. Why would we do that? We did that for a number of reasons. We wanted patients to be educated. I want every patient that I'm responsible for to know as much about that disease as possible. So if you think about something real simple, you or I prescribe a medication. Let's say it's beta blocker, and the patient says after 3 days, I don't feel good, I'm going to stop this medication. If I had taken the time to explain to that patient, you may feel bad for a week or two, but after 2 weeks you'll feel better, that patient would have not stopped that medication. So another simple but very important area is fluid retention and diet. And I tell patients, you have your hands on the wheel, your foot is on the gas pedal, and you can control how much fluid is in your body based on what you do, how much salt is in your diet. So once patients understand how much input they have, I think it leads to far better outcomes, of course.
So that's great. Yeah, so the patients, in fact, is a partner in the care, and they can be in charge of components of their care. Absolutely. As well. I know another initiative that they've been undertaking in the Heart Failure Society, and we're absolutely delighted. For example, you're here today is the international collaborations. Heart Failure Society is really now, sort of international organization. Are there things that you think, certainly Cleveland Clinic and the Heart Institute, or between U.S. and Canada, can actually do together, to actually help to advance the field and in terms of, making better, days for our patients?
So absolutely, and I just want to take a chance to comment that the Canadian Heart Failure Society and the Heart Failure Society of America have an official assigned agreement where we have joint sessions at our respective meetings, and we are, with the cooperation of Shelley Zeroth and Justin Zekowitz and others, working toward even closer collaborations, which will be in many domains. As far as Ottawa and Cleveland, you're on the north end of the lake, we're on the south end of the lake, so we're neighbors. And I've just learned in the last 24 hours that we share an electronic health record vendor. So I am already thinking of opportunities of how we can collaborate in heart failure, because whether you use the term artificial intelligence or data mining or electronic health records, I think we would all agree that with the current technology that we have, we're only scratching the surface to harness what we can obtain. So collaborations and joint efforts to combine databases, I think, are going to be very important.
Oh, that's very, very exciting. In fact, when we started our EMR, electronic medical record system, we visited the Cleveland Clinic, to actually understand the impact. And we, really look forward to this. And we are here, using science and research to break down the walls, between countries. Right. And so I think that wraps up our interview today. And so it's been so exciting. And thank you so much, Dr. Starling, for joining us here in Ottawa and speak to us about the latest advances in this very, very important field. And that affects more and more patients, not only in Canada, but around the world. And thank you for your efforts as well as a leader in the field, being president of Heart Failure Society, and bringing so much, to our patients and to international collaboration.
Thank you.
Take care.
Thank you.
I was born in 1976. I grew up here. This building is who I am. The patients, doctors, nurses, and staff, they truly are my family. Some thought I wouldn't make it, but great leaders fought for me. They believed that I could change Ottawa, Canada, even the world. And they were right. By the time I was 30, I'd saved thousands of lives, was recognized internationally, and had collaborated with over 40 countries. I've performed over 500 heart transplants, discovered the world's first genetic risk factor for heart disease, combined care, research, and education in one place, leading the way for innovation in heart disease throughout Canada and the world. I'm always thinking of the future and learning from the past. But through all this, I couldn't have done it, not without the people. The people here have taught me that through great loss can come great triumph, and that fear is never as strong as hope. I can't stop until there's a cure, and I will spend every second of my life trying to save yours. Some might say I've lived 1,000 lives, but I feel I'm just getting started.
This is quite a day for healthcare in Ottawa.
Doctors, nurses, volunteers, board members. It takes a community to build a place like this.
We will be able to perform more procedures, reducing waitlist in open heart surgery as well as in non-surgical procedures. The total of complex surgical and non-surgical interventions here will be over 12,000 a year.
Welcome to our home and your home from the bottom of our heart. Thank you very much.
I think it's enlightened.
It's an amazing.
Out of this world.
Magnificent.
Beautiful.
Incredible. amazing. Yeah.
It's like going to the Star Trek age because the technology here and all this is compared to before. So imagine how patients are going to feel when they're being treated here.
We're very pleased to have this new facility. It's going to be a tremendous improvement for our patients. Currently, they're in an area that's quite crowded. There's not a lot of space for their families when they come to visit, and it's certainly older. So now we're in this bright new facility. There's all sorts of space for them, and there's places for families. There's a terrace for patients who have to stay a long time. So it's going to be a huge improvement for the staff, but more importantly for all of the patients.
There's air everywhere, so there's nothing, and that's very important, and windows, because people after surgery, they get disoriented if they can't see outside. So there's windows in every place, and that's very, very important.
This is a moment we are waiting for the last 12 years. I mean, this is a brand new facility which is adjacent to our current facility that will include all the operating rooms, the intensive care beds, and which is serving 80% of our patients, because most of the things we do at the Heart Institute is very advanced cardiovascular care with open heart surgery, with high-tech medicine.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country. Good morning and welcome back to Beats Research Radio for our second segment with Dr. Starling. My name is Hallie Arnott and I am the Canadian Biomaterials Society Ottawa Student Chapter President and a graduate student in biomedical engineering at the University of Ottawa. Today I'll be your host for this second segment with Dr. Starling. If you missed our first segment, Dr. Starling is a world-renowned cardiologist working at the Department of Cardiovascular Medicine at the Cleveland Clinic. Specializes in the care of patients with acute and chronic heart failure, as well as patients with heart transplant. He's also the medical director of the Kaufman Center of Heart Failure and the president of the Heart Failure Society of America. So thank you for being with us here again today for the second segment.
Thank you. It's a pleasure to be here today.
Do you mind telling our listeners a little bit about your background, how you found yourself working specifically with heart transplants?
So that is
maybe briefly.
yeah, that could take me a while, but actually, there's a very interesting sidebar to the whole story. So my name is Starling, and every medical student is educated their first year on Starling's law of the heart. So I have some DNA in my system that goes back quite a ways to a physiologist in London that was one of the scientists that worked with Otto Frank that wrote Starling's Law of the Heart. So he was a heart failure physiologist. So I didn't know this, obviously, when I was growing up, but had an interest in medicine. I grew up in Pennsylvania and did my undergraduate work in biology, developed an interest through family members, others, and ultimately went to medical school. In medical school, I had some very unique opportunities that came along, and that as a senior medical student, one night I was on call, and they were in the midst of planting a mechanical heart in a cadaver, someone that had just passed away, part of an experiment. So it was almost like things kept happening to me that were sending me a message. And then I went on to do my residency, and lo and behold, there was an individual who is a giant. He's passed away, Thomas Starzl, who championed the development of immunosuppression. So at the beginning of my internship, they were doing heart transplants in New York, one of the few places in the country. So it sparked my interest, and I ultimately started to do research. And as a resident before I left Pittsburgh, and my interest in transplantation and heart failure really came up that way. But the important thing that I would mention is that it was emphasized to me early on the importance of research in the context of measuring what you're doing, looking at the outcomes, figuring out what needs to happen to make it better.
So in heart transplantation, there's an amount of clinical trials that need to occur before things are way too. So would you mind telling us a little bit about how these clinical trials and clinical studies have evolved over the years and how maybe they're different from when you first started to how they're now?
So if you look at transplantation, which has been around about 50 years, so as I mentioned, in the early 1980s, cardiac transplantation was going nowhere in the United States and the rest of the world because the outcomes were very, very poor. The one-year survival rate was approximately 20%. So along came a new immunosuppressive. The name was cyclosporin. So a unique drug, a so-called calcineurin inhibitor that radically changed, in my opinion, the field of solid organ transplantation, specifically heart transplantation. So in 1984, in the US, this new drug was approved. After the approval of that drug, the number of transplant centers in the US went from less than 10 to almost 150. And consistent with that were improvements in outcome. So what we have seen happen over the years are a series of clinical trials, new pharmaceuticals, trying to continually improve outcomes, but also acknowledging two other important areas. One, how can we reduce some of the morbidities after transplant, which include infection and include actually the development of blocked arteries in the transplanted heart. We call that vasculopathy. And number two, the current best way worldwide that is considered to monitor a patient after a transplant is to take a catheter that goes in through the jugular vein, goes into the heart, a biopsy is taken, and then that has to go to a pathologist to be processed. Well, that's been around for almost 50 years. But where is the field moving? It's moving non-invasive diagnostics that are primarily based on gene expression profiling, cell-free DNA, and other newer molecular techniques.
So some of the remaining challenges
other than coming up with more non-invasive options for these patients? You see, so what are some of the other remaining challenges?
Well, I think that there is a very important paper that was written in a medical journal from the University of Ottawa.
Okay,
Dr.
good.
Beanlands and other colleagues. And the title of this essay, if you will, was Cardiac Allograft Vasculopathy, the Achilles heel transplantation.
Okay.
So, as I mentioned a little earlier, the new arteries in a transplant patient can develop blockages. So that's vasculopathy. The challenge that we have is how to prevent it, how to diagnose it, and actually the University of Ottawa Heart Institute has been at the forefront of some of the non-invasive techniques with nuclear imaging to make the diagnosis. Having said that, we still don't know for sure how to treat it.
Right.
And we are approaching these patients after transplant, just like we do patients that haven't had a transplant. They get a catheterization, and many times they get a stent put in the artery. But we have a long way to go, I think, to solve this.
With some advancements that you maybe foresee in the short term and possibly the long term for heart transplantation, see anything emerging as something that's going to be very beneficial for these type of patients?
Well, I think that we should acknowledge that another big problem with transplant is the lack of donors. So a lot of research and emphasis should go on how can we expand the donor pool. So one way that that has happened fairly significantly in the US and probably Canada is hepatitis C. So up until recent, transplant centers would not accept a donor heart from an individual that had evidence of hepatitis C infection. We can now cure hepatitis. So it is being established as we speak as the new norm is to accept these donor hearts and then treat the patient and cure them of hepatitis C. The other area that is an unfortunate one is that as the number of deaths from opiate overdoses has increased, again, at one point in time, it was felt do not take a donor organ from someone that has had a drug overdose. Nowadays, at least in the US, it is commonplace. And recent reports in very prestigious medical journals have provided very encouraging results that the outcomes are equivalent.
So would you be able to tell us a little about the criteria that a patient would to present with in order to receive a heart transplant? I know in some cases you either be too sick or possibly not sick enough for this type of surgery. So would you be able to give us a little bit of insight on that?
So that's a very important question. And let me frame it by saying that many patients come to my office for a second or third opinion, petrified and terrified because they've been told you need a heart transplant and there's nothing else that can be done for you. The good news is that many times that's incorrect, and many times the patient has many other options that can be recommended that will improve their condition. It's a very fine line to pinpoint the patient that is sick enough but not too sick, because as kidneys fail and other organs of the body fail with advanced heart failure, the patient's risk for a transplant could become prohibitive. So we do some relatively simple tests. So one, does the patient have the proper diagnosis? 2, based on the proper diagnosis, they've been treated perfectly. 3, if those conditions are met, then what is the patient's degree of functional impairment?
Right.
So the gold standard is to put the patient on an exercise test, and if that individual can do 50% or less of what is predicted, then in general, that functional limitation is considered to be significant and the patient should be considered for transplant, assuming that all their treatment up until that point has been ideal.
Okay. So for somebody who is at risk, would you be able to give any advice on, maybe what would be a risk factor that somebody would prevent or the likelihood of requiring a heart transplant, or maybe a risk factor where they have a transplant and possible rejection?
So let's take the first part initially. So in the United States, if a patient is smoking,
Okay.
they are told you cannot go on the transplant list. And the typical recommendation is you must be tobacco-free for 6 months minimum before you can be listed for transplant. That is based on good scientific evidence that the outcomes are affected if the person is affected. So the heart failure patient that is getting close to maybe needing a transplant that's actively smoking, they have to be educated. You better address this, or if and when the time comes, this could stand in the way of you being on the transplant list.
Right.
The second area that is also related to some degree to behavior is obesity. So there is body mass index criteria in the US. So a very obese patient will be considered contraindicated to transplant at most sites in the US. So we even have patients now that are being referred for bariatric surgery if needed to achieve a goal body weight so they can get on the transplant list. As far as problems after transplant, probably the biggest one that we pay attention to is if the patient has had a malignancy. So whether it's lung cancer, breast cancer, colon cancer, melanoma, prostate cancer, all of these cancers are looked at very carefully. The amount of time since the diagnosis and the cure factors in as to whether the patient will even be eligible to go on the list. And what we're trying to achieve is a patient that after transplant, when they are on immunosuppression, prevent rejection, that immunosuppression doesn't put them at risk of a recurrence of their malignancy.
So that recovery process is quite lengthy, especially for those patients who already have that malignancy. So, and being on those suppressants, what is the recovery like for somebody who have had a transplant?
So the recovery is variable, and it is similar to any other major operation in the context of if a patient is bedridden before an operation, they're going to have a longer recovery. If the patient is up and mobile, walking, they're going to have a quicker recovery. If a patient has frailty, if it has what's called sarcopenia, which means they're losing muscle mass, they're so ill that their body is deteriorating, they're going to have a very long, probably 6 to 12 months before they're in tip-top shape. Now, I once got a question from the media about an individual that was the CEO of a big company that had a heart transplant, and the people in that company and the stock market was wondering, will this CEO ever come back to work?
Right.
And so they checked with a number of transplant experts in the US, Some said 6 months. Some said, that patient can't fly on an airplane for
variable
months.
answers.
And my answer was, patient could go back to work in as soon as 3 months if they are in good physical condition. So that incision healing and the heart working well happens relatively quickly. It's really a matter of how debilitated was the patient before they went to the operator.
So getting the blood flowing as possible is helpful. And so would you recommend a little bit of exercise, or is that even possible for post-op?
Not only do we recommend a little bit of exercise, we recommend full cardiac rehab.
Okay.
So a patient after a transplant, as soon as they are able to walk on a treadmill or pedal a stationary bike, with some patients that's 1 month, some patients 3 or 4 months, but we order and recommend a full 36 sessions cardiac rehab, and it's been shown and published that those patients have better outcomes.
So do you think you could tell our listeners, if you could tell them one thing about heart health and maybe how to reduce risk of developing heart failure and the requirement for a transplant? Like, what would be maybe your one piece of advice for us?
So I think my one piece of advice is eat right and exercise.
Okay. I feel like everyone's trying to do that. So great piece of advice, and thank you very much for tuning in with us at Beats Research Radio. Thank you, Dr. Starling, for being here. Before we go, I would like to thank the University of Ottawa Heart Institute, eLife, the Canadian Biomaterials Society, Ottawa Student Chapter, and the Beats Research Lab for supporting our endeavor here at Beats Research Radio. Thank you very much, and see you next week.
Beats Radio, scientists interviewing scientists. Canada is a worldwide leader in science and innovation. However, our communities need to be more connected to current scientific research in order to drive the future of scientific innovation. So what steps can we take to more actively engage and connect our community with scientists and vice versa? Innovation and discovery are at the core of the current efforts of our government, but science sometimes gets slightly complicated to understand. At Beats Radio, we will tackle this by having young scientists and early career researchers interviewing scientists and innovators. By dissecting science in simple terms, this will allow our community to better understand the importance of science for our country.